Спасибо. Thank you for the invitation again. In the next 20 minutes I'm going to talk about endosonography for mediastinal staging in lung cancer. I will focus on how you can use endosonography for staging of lung cancer for the tumor, for the nodes, and for the distant metastasis. And I will focus on the lymph nodes. Just a quick recap. I think you all know we stage the lymph nodes in lung cancer from N0 to N3, where N0 means no lymph nodes, N1 means higher lymph nodes, N2 mediastinal lymph nodes, and N3 ipsilateral lymph nodes. So why are these lymph nodes so important for lung cancer? Why is staging at all important? Why do we stage these patients? We do stage patients with lung cancer because it guides the prognosis of patients and it guides your treatment options. So in the absence of distant metastasis, the intrathoracic lymph nodes become crucial for your treatment decisions. Because when there are mediastinal lymph nodes involved, then you don't perform a surgery as an initial step in these patients, but you go for radiation therapy, chemoradiation therapy. So if we start with, we have a patient with lung cancer, we perform a CT scan, and for nodal staging, we look at the CT and we see that actually the accuracy for CT scan for investing the mediastinum in a patient with lung cancer is actually quite poor. Dr. Silvestri performed the meta-analysis and showed that the sensitivity was only 55% and also the specificity was 81% if you take a cutoff point of 10 millimeters for positive lymph nodes. So we cannot base our treatment based on the CT only. Luckily, we also have the PET-CT. PET-CT is doing better for mediastinal lymph nodes metastasis, but still you cannot rely only on imaging for staging the mediastinum. When we have a small tumor without any lymph nodes involved either at the CT or at the PET scan, then you can be positive that there won't be any lymph nodes in the mediastinum. But for in patients with lymph nodes in the hilar or a big tumor, then the negative predictive value of PET-CT for mediastinal disease is actually too limited to guide your treatment based on that. And that's why guidelines advise you, in those cases, in patients with a suspected mediastinal lymph node metastasis, you should get some tissue verification. And how, for years we did that, we asked the surgeon to perform a mediastinoscopy. But now, I'll show you the Big Yama paper, landmark trial, where they compared mediastinoscopy, what was the gold standard for them, to endosonography for mediastinal nodal staging in patients with lung cancer. So in the Aster trial, they included patients with lung cancer who had an indication for mediastinal tissue staging based on the CT scan. So either a big tumor, as you can see on the left image, or suspected mediastinal lymph nodes, as you can see in the middle picture, or patients with a centrally located tumor, as you can see in the right image. And all these patients had an intention for surgery if the lymph nodes in the mediastinum were not involved. So the Aster trial showed us that mediastinoscopy had a sensitivity for detecting mediastinal nodal metastasis of 79%. The other group, the endosonography group, where the patients received both an EUS, so from the esophagus, and an EBUS procedure from the airways, the sensitivity for detecting mediastinal metastasis was 85%. And they showed that when you combine endosonography, if the results were negative, it was followed by mediastinoscopy, you increase your detection rate for mediastinal metastasis to 94%. So based on this landmark trial, the guidelines were changed and they advise us now to perform endosonography in case of mediastinal nodal staging when it is indicated based on the imaging. So if you have a suspected mediastinal lymph node or a suspected hilar lymph node or centrally located tumor or a big tumor, you have an indication for endosonography. But the guidelines don't tell us how to perform an optimal endosonography. Do you have to perform an EBUS, or do you have to perform an EUS, or do you have to do both? And can we do a hit and run technique, or can we have to sample all the lymph nodes? The common practice actually is that people perform a targeted EBUS, where they look at the CT scan, as in this case, you see an enlarged and FDG-FIT station 4R, and we perform an EBUS procedure, go for 4R, take the biopsies, and leave. Although this is quick and straightforward, it might have a risk of understaging the patient. You can miss lymph node metastasis on other stations because you simply don't look at it. So we think you should perform a systematic EBUS procedure, and you can do that by the images of our colleague from Copenhagen, Professor Clemensen, who showed us that you can do it in a systematic way, where you introduce the EBUS scope into the airways, in the trachea, and look at the mediastinal lymph nodes and the hilar lymph nodes. And in the image on the right, you can see that with EBUS from the airways, you can reach the mediastinal lymph nodes and the hilar lymph nodes. These are the yellow dots. But you still miss some lymph nodes that are in the lower mediastinum. So when you perform an EUS procedure from the esophagus, and you can do that either with the EUS, conventional EUS scope, but you can also very easily introduce the EBUS scope into the esophagus, which is pretty much more convenient for the doctor and the patient. Then you can assess the lymph nodes in the lower mediastinum as well. And the esophageal route has another advantage, because you don't have cartilage rings there, so it's easier for you to sample, and it's often tolerated by the patients. And if we look at the added value of performing an EUS or EUSB with the EBUS scope after an EBUS procedure for detecting mediastinal metastasis, a meta-analysis published in the Lancet Respiratory Medicine 2 years ago showed us that you find an increase of 12% in detecting mediastinal metastasis. So this has huge implications for treatment of these patients, because these patients don't go for surgery straight away. We conducted the SCORE study after the ASTER trial, where we hypothesized that it would be, if you perform a systematic EBUS procedure, followed by an EUSB procedure, where you routinely and systematically assess the lymph nodes from both the airways and routinely sample the lymph nodes in station 4R, 4L, and 7. And after that, you introduce the EBUS scope gently into the esophagus and perform a systematic evaluation from the esophagus as well. That this approach would improve mediastinal nodal staging compared to the targeted hit-and-run EBUS procedure, which is common practice. And what we found, that indeed you find an increase of 9% for detecting mediastinal metastasis when you perform a combined an EBUS procedure with EUSB procedure with routine sampling of these lymph nodes. The hit-and-run EBUS procedure had a sensitivity of 73%. When you perform only a systematic EBUS procedure, the sensitivity increases with 4%. But if you put the EBUS scope afterwards into the esophagus, you find another 5% increase in mediastinal metastasis. And actually, you can do this with one doctor, with one scope, in the same setting. So, therefore, we concluded that a systematic EBUS procedure with routine sampling, followed by an EUSB procedure with the same EBUS scope by the same doctor, improves mediastinal nodal staging compared to the hit-and-run strategy. And this should be the way to assess the mediastinum in patients with lung cancer. Now let's move over for tumor diagnosis and endosonography. I think you all know we stage a tumor from T1 to T4, where T1 is a small tumor, T4 is a big tumor, but also T4 can be a tumor which invades the mediastinum. And now I'm going to show you in the next slides how endosonography can be used for assessment of the tumor, for both getting a diagnosis, because before you have to treat the patient, you have to get a pathological diagnosis of cancer, but also for staging the tumor. And when we have a patient with a tumor, as you can see on this CT image, it can be quite hard to get a pathological diagnosis, because when you perform a bronchoscopy, chances are very big you won't see any endobronchial abnormalities. And you need a pathology to guide your treatment. So diagnosis in this case can be quite challenging. When you perform an EBUS procedure in patients with a centrally located lung tumor, a colleague of me, she performed a meta-analysis in over 1,000 patients, and she found that the diagnostic yield of EBUS in these cases, so with a patient with a centrally located lung tumor, is almost 90%. And she found there were no serious adverse events, and only 2.5% of the patients had minor complications. And pneumothorax, you might think that that's a risk, only in 1.5% of the patients. So she concluded that EBUS TBNA is safe and has a high sensitivity for diagnosing centrally located lung tumors. Sometimes the tumors are not located adjacent to the airways, but are adjacent to the esophagus, so are lower in the lower lungs, in the lower lobes. And you can also investigate these tumors from the esophagus by introducing either the EBUS scope or the conventional EOS scope of the GI doctors into the esophagus for assessment. A systematic review from 2016 showed that also with EOS from the esophagus, the diagnostic yield is actually quite high for getting a diagnosis in centrally located lung tumors. But what about assessment of the T status? So not only getting a diagnosis, but also assessing whether or not the tumor is invading the mediastinum. Can you do that based on CT, or can endosonography be helpful for that? Especially, for example, this case, patient with a centrally located tumor adjacent to the aorta. Do we know it's invading into the aorta? If we perform an EBUS procedure, we can very nicely visualize the tumor lying behind the aorta, which you can see here. Can you see? No. With the color Doppler is the aorta, and lying behind you see the tumor. Hopefully this image, no. I had a really nice video, but unfortunately it's not working. But the good thing about endosonography is that it's a dynamic investigation. So you can see actually the tumor moving along the aorta. So then you can see that it's, at least on that spot, it's not invading. So Dr. Kuivenhofer performed a study where they looked at EOS or EOSB for T4 invasion, and they at the reference standard they used resection. So all patients had the tumor was resected afterwards. And what they found is when you have only CT or only EOS, the sensitivity and negative predictive value is not high enough. But when you combine those two procedures, you get a sensitivity of 83% for diagnosing a T4 tumor, and a negative predictive value, and that's even maybe more important. So you can exclude tumor invasion in 79%. So this has implications for the surgeon, for surgery, if you go for surgery or prefer chemoradiation therapy. So I showed you that endosonography can also be used for tumor diagnosing from centrally located tumors, either adjacent to the airways or adjacent to the esophagus. And you can also use endosonography for staging the tumor to assess the invasion in the mediastinum. So now let's move over to distant metastasis. We all know if patients have distant metastasis, that has a huge implication for patients because you cannot treat them with curative intent anymore. So we know one of the predilection sites for distant metastasis are the brains, the bones, the liver, and the adrenals. So how can endosonography be useful for that? In the next few slides, I'm going to focus on the left adrenal gland with endosonography. But we also know that endosonography can be useful to detect liver metastasis and lymph nodes in the abdomen. So the left adrenal gland, it's a predilection site for metastasis, but even we know that in patients with lung cancer and an enlarged left adrenal gland, chances are bigger that it's a normal adrenal gland than it's metastasis. So guidelines state that when you have an enlarged adrenal gland, that you have to get a diagnosis. And guidelines advise you to perform an EOS with the conventional EOS scope. And our colleague Dr. Schuurbiers, she showed that the sensitivity for detecting left adrenal gland metastasis is 86% with the EOS scope. And she showed that when you have a loss of seagull shape, that is a predictor of metastasis as well. But in most patients with lung cancer, we also have an indication for mediastinal nodal staging. And that we do with the EBUS scope because simply the big EOS scope does not fit into the trachea. So we wondered if we can perform if we can analyze and visualize the left adrenal gland with the EBUS scope after the nodal staging. And when we perform an EOS from the esophagus, we start with a systematic inspection of the mediastinal lymph nodes. But after that, we go into the stomach, and we can visualize the liver, the aorta, and the left adrenal gland. So, how should you do that? When you performed your EBUS procedure for your nodal staging, then you introduce your EBUS scope into the stomach, and then you see the liver, which you can see on this image. And then, if you turn your endoscope clockwise, you will find your aorta, and when you press a little bit deeper, you can find your left adrenal gland with the left kidney on the left and the left adrenal gland like a seagull. So in a retrospective analysis, we analyzed if it was feasible to detect the left adrenal gland with the EBUS scope. And what we found that in 85% of the patients, we could find the left adrenal gland after mediastinal nodal staging with the EBUS scope in patients with suspect of lung cancer. After this study, we also wanted to compare the EBUS scope not only for visualizing the left adrenal, but also for sampling the left adrenal. So we conducted another trial where we compared the EBUS scope with the conventional EOS scope, the gold standard for assessment of the left adrenal gland. And what we found is that the success rate for left adrenal gland analysis, and success was defined as that we could see it, we could sample it, and we obtained adequate tissue, that was actually similarly high. With the EBUS scope, the success rate was 89%, and with the EOS scope, the success rate was 93%. So we concluded that left adrenal gland analysis with the EBUS scope has similar success rate in comparison to the conventional EOS scope. So in the last 15-20 minutes, I showed you that endosonography can be used for staging of lung cancer, not only for nodal staging of lung cancer, but also for assessing the tumor and for also assessing the distant metastasis. And I think that when you can do the whole staging process with just the EBUS scope, which is convenient and spares cost because you don't need the big EOS scope. And we state that with a single EBUS scope, with one doctor in one session, you can get a diagnosis, you can stage your lymph nodes, and you can assess the left adrenal gland in the same session. So we think that this is the way you should stage patients with lung cancer. Thank you for your attention.
Thank you so much for that presentation. You're really exactly in your time. Thank you so much. We're waiting here as a chair. Коллеги, мы просто немножечко должны идти по времени, поэтому я думаю, что мы вопросы сможем во время перерыва спокойно обсудить. Я обещаю лично обеспечить вам перевод, хорошо? У нас следующий доклад должен был прочитать профессор Виктор Викторович Соколов, но у нас приболел, и докладчик должен быть Андрей Михайлович Князев. Есть у нас Андрей Михайлович в зале? Нет, Андрей Михайлович, задали, поэтому пока мы вот этот доклад мультимодальной бронхоскопии очень интересный, пока пропустим. И следующий докладчик у нас Игорь Владимирович Васильев, диагностическая бронхоскопия в 21 веке. А пока Игорь Владимирович готовится, у нас Валерий Николаевич пару слов, я думаю, скажет относительно предыдущего доклада.
С удовольствием выслушали такую учебно-познавательную лекцию наших коллеги из Нидерландов. Друзья, у меня вот такое, ну как призыв что ли, что каждое эндоскопическое отделение, которое обслуживает большие отделения торакальной хирургии, наверное, должен иметь вот в своем арсенале исследования с помощью конвексного датчика и биопсии, прицельной биопсии с помощью ультразвукового наведения. Это во многом определит успех выполнения хирургических операций, повысит информированность врача-хирурга о состоянии патологического процесса. Поэтому я думаю, что мы вот здесь все единодушны во мнении, что надо как можно больше усилий приложить для того, чтобы все клиники были оснащены этим оборудованием.